I'm Jason Connor, a clinical trial designer with Barrett Consultants. Today I'm going to talk about the value of biomarkers in personalized medicine. We're hearing lots more about personalized medicine, and it's kind of self-evident what that means to patients, but what does it mean for us as clinical trial designers? So imagine we have a new treatment. Standard of care works in about 40% of patients. That's what I'm showing here in green. The new therapy works additionally in another 10%. So it works where the standard of care works, but now it works in another 10% of patients too that I'm showing here in purple. And unfortunately, still nothing works in 50% of patients. So just in this hypothetical case, I'm going to talk about a cure. So imagine patients are either cured or not, simple dichotomous outcome. So, one question for us as trial designers is how many patients do we need to have a 90% chance to see a statistically significant result? This is what we do all the time when we power trials. So I'll leave it to you to guess or pause for a second. How many patients do you think we need for 90% power to show a difference or an improvement from 40% in the standard of care to 50% with our new therapy? So if you guessed about 1,000, you're right. So if we have 1,036 patients with a standard chi-squared test, we have 90% power to show an improvement from 40% to 50%. But what if we knew which patients were most likely to benefit? So here, what if we knew who these purple patients were? The problem in a standard clinical trial is 90% of the people we enroll aren't actually telling us much. 40% of the patients we enroll are going to get better on either treatment. 50% of the patients we enroll, unfortunately, aren't going to get better either way. So it's really just these purple patients. Of course, patients aren't purple and we don't know who these 10% are that differentially get better between the standard of care and this new therapy. But what if we knew which 10% of the patients were the patients that would actually benefit under this new therapy? How many patients would we need then? So I'll give you another second to try to guess here. What if we knew which 10%? How many patients would we need for 90% power? So if you guessed 8 patients, you're right, and the first person that's gotten this question right, I think. So in this case, of course, none of the 4 patients we put on the standard of care would be cured versus all 4 on the new treatment. So even in this super small sample size case, a Fisher's exact test gives a significant p-value here. Of course, FDA wouldn't and shouldn't agree to an 8-patient trial. We still want a larger patient experience for things like safety and things like that. But the key is if upfront we can identify in whom a new therapy is going to work, we can dramatically shrink the size of confirmatory trials. But of course, perfect prediction, is unlikely. So what if we just sort of knew? So now imagine instead of perfectly identifying who these purple patients are, doing genetic analyses, using some sort of biomarker, even if that's a little bit imperfect. So to identify this 10% of patients, we misidentify another 10%. So 25% of the patients will enroll. They're still cured by the standard of care. 25% aren't by anything, but 50% of the patients we're going to enroll in our clinical trial now will be differentially cured by our new therapy. In that case, even with this imperfect biomarker, we still only need 36 patients for 90% power. And even if our predictor is worse, even if we kind of only sort of knew which 10% benefits, and now we're going to enroll 2 patients for whom we make a mistake with our biomarker for every 1 that we correctly identify using our biomarker, we still only need 90 patients to have 90% power. So we can run dramatically smaller confirmatory trials if we have really effective biomarkers that predict who's most likely to respond for a new therapy. So in summary here, by using biomarkers that are highly predictive of who will benefit for a new treatment, we can make confirmatory trials much, much smaller, and this can lead to personalized medicine. That's the easy part, doing a small phase 3 trial. The hard part, of course, is identifying biomarkers that are going to really predict well what patients are going to benefit with a new therapy. For that, we probably require larger phase 2 platform trials, more data sharing, potentially even across sponsors, and probably want to incorporate adaptive randomization to most efficiently identify what treatments will work in which patients. Thanks for watching.